Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri,
And I'm Andrew Sanchez.
and we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed.
All right, we are back. And Mike, I'm going to try and do a better job here because we had a guest 2 episodes ago. And in listening to that episode, I realized we did such a bad job introducing Alec. Alec, I'm sorry. I know you're listening to this. Everybody, go on the website and please pull up Alec's episode to learn a little bit more about him. There's a great photo of him there as well and his case photos. But we have another guest here today, also from the Clinical Problem Solvers, Maddie Conti. Can you say hello, Maddie?
Hello. I'm so happy to be here. I've been listening to these episodes on my commutes to work. So I'm so excited. I feel like I've heard about your lives when listening through the podcast, like Mike, rock climbing, Andrew, rollerblading, your dog. I feel like I've heard about your lives. It's been awesome.
That was the whole purpose. Yeah, it's not medicine. It's just a diary from Andrew and I about the various things we're doing. Glad we've checked the box.
Yeah. And I just now realized I still did not truly formally introduce Maddie. So Maddie is one of the most high up people at Clinical Problem Solvers. Maddie, what's your exact title at the Clinical Problem Solvers right now anyway?
Co-director of internal operations alongside Yusuf.
Yeah, so you can't get much higher than that. I remember when I was an intern, I had taken probably like 6 months off from VMR and I had returned back to the space, and Maddie was just like out there just presenting so many cases and doing so many things, and it's really cool to see progress and now be here on the podcast. So thanks for being here, Maddie. Fresh from Colorado, what do you have for us today?
Oh, right. I have a great case for you that I saw very early on in my intern year that stuck with me. So I'm really excited to share it with you. So this is a case of a 62-year-old man. He has a known history of prostate cancer, and he was sent to the emergency department because he was found at his chemotherapy infusion session to have a white count of 3, a hemoglobin of 6.8, and platelets of 23,000. So he was told, you should go to the emergency department. And I'll pause there.
Ooh, Mike, do you want to kick us off?
Absolutely. Thanks so much, Maddie. That's a great case. I feel like I'm this is something I'd be ripe to anchor on. So I'm happy to start discussing. I think that, it sounds like this is new pancytopenia, which is why he's being sent in, but that would be an important context to know is, were these counts similarly, or is it he's just being sent in because his counts on chemo, just the hemoglobin's dropped low enough that they need to go to the emergency department to get blood. So I think trajectory is always helpful when you're talking about pancytopenia. And additionally then, right, like what sort of triggers for pancytopenia, and he's on chemotherapy, so I would want to know what kind of chemotherapy, and is it something that's known to cause myelosuppression, because oftentimes that'll happen, right? Someone is like, quote, on chemo, they're getting immunotherapy, and the pancytopenia is not necessarily from that, right? So I think I know I've made that mistake many times where I just sort of assumed all chemo causes pancytopenia, but of course that's not the case. So I think that's where I'd start, and I'll hear what you have to say as well, Andrew.
Yeah, I think I recall many admissions on the Duffy service for pancytopenia in the setting of chemotherapy. I couldn't rattle off all of the chemotherapy options for prostate cancer, but that said, I feel like we didn't have many of those types of patients come in with pancytopenia from prostate cancer, particularly because many of the therapies are hormone based and don't really touch the bone marrow. So I guess I would just be curious to hear more history from the patient, because if they don't have a drug exposure that's causing this myelosuppression, then the differential's wide open. So I'd be curious, is this guy's been having kind of low grade fevers for a while? He hasn't been feeling so hot. He's been a little short of breath. Has he been having any abdominal discomfort or diarrhea? Just anything to kind of latch onto, because absolutely, if he has a drug exposure that explains it, our job's kind of done. But I'm very curious to hear kind of what's been going on in terms of any signal from any organs in his body, if he's been feeling anything. But yeah, Maddie, what was like the HPI you all got from him?
Yeah, absolutely love that discussion. So, yeah, so exactly as I mentioned, so history of prostate cancer, and actually the day of admission to the emergency department, he had gone to his infusion center, and this was actually going to be his first dose of chemotherapy. So he had not yet received any. So at the infusion center, labs were done, just kind of on routine before his day one, cycle one. He was about to get docetaxel and Lupron. And then in terms of kind of how he had been feeling, he said he'd been feeling a little bit lightheaded and dizzy for about the past week, but really not too many symptoms. He was not having any chest pain, no shortness of breath, no fevers, no chills, no diarrhea. He was really just kind of bummed to be in the emergency department because he was so excited to start his first session of chemo and was really bummed that he couldn't get it because of these low blood counts. So that's really the information in the HPI. For info on the past medical history, so as I mentioned, prostate cancer, this was diagnosed 2 years ago in the setting of an elevated PSA. And he had previously been treated with androgen deprivation therapy and radiation therapy. And he had known actually metastatic disease. He had had a PET image that had shown basically metastases in his bones, in his axial skeleton. And so he has had back pain from those bony mets and is on dexamethasone for that, for kind of the back pain from those bony mets. He also has a history of hepatitis C that he's received treatment for, that has been in remission. The viral load has not been elevated. Has a history of COPD that he takes Symbicort, Spiriva for, and at baseline wears 3 liters of oxygen. And he also has a history of pulmonary sarcoid. It has had biopsies of his lymph nodes in the abdomen and the chest that showed non-caseating granulomas consistent with sarcoid. And treatment for his sarcoid has included methotrexate and prednisone, but he was no longer on either of those. So that's kind of his past medical history, medication, social history. He lives in Colorado, has lived there his whole life, lives in a long-term care facility, has family nearby. Formerly was a smoker, smoked about a pack per day for about 30 years, but no current smoking, no other relevant drug use. And then I'll kind of bring you to the vitals and the physical exam. So in the emergency department, his blood pressure was 120/82. His heart rate was 115. He was satting 96% on his baseline 3 liters of oxygen, respiratory rate 16. And physical exam, he was overall quite well appearing. As I mentioned, he was just very bummed to be here because he was so excited to start his chemo. But kind of EGE and T exam was overall unremarkable, did not appreciate kind of conjunctival pallor. There was no lymphadenopathy. His heart exam was normal. There were no murmurs. Lungs, there were no wheezing at all. Abdomen was soft, non-tender, non-distended. No rashes, no lower extremity edema, really no abnormal findings on physical exam. And maybe I'll pause there.
Yeah, I can start. Super interesting story, Maddie. Thanks for presenting it in the way you're presenting it. My just first 2 initial impressions, it sounded like this anemia he's experiencing is symptomatic. It sounds like he's feeling pretty crummy and tired. And when you couple that with the heart rate being in the 110s, certainly an abnormal finding, it makes me think that the tempo of this pancytopenia is on the more acute to subacute side because he's feeling it. If it was more chronic, he probably would have adapted to it and been less symptomatic and not shown that heart rate response. So I'm starting to feel a little bit more pressure that we need to solve the problem on the quicker side, as I get the sense now that something's shutting down the marrow. And I'm still focused on the marrow because of what Mike taught us in our episode about anemia. When multiple cell lines are down, we focus on the marrow first, just because the probability of a marrow issue trumps the probability of a destruction issue. And of course, we should go through kind of all of the causes of marrow failure for pancytopenia and just start with the basics being the building blocks for our cell development. And a favorite of the podcast, B12. We're just commenting on this. I don't think that's what this is going to end up being, Mike, because of the tempo. It's more of a chronic thing, but just for the listeners, ineffective hematopoiesis, you need to think about the building blocks and whether they're deficient. So your megaloblastic anemias, make sure you're testing for B12, copper, and all of those sorts of things. And then other things that can cause pancytopenia, just in terms of big buckets, there's something called hypoplasia, and that basically refers to marrow shutdown for a variety of different reasons kind of external to the marrow, like sepsis can do this, toxins can do this, like if you're drinking a lot of alcohol, which this patient isn't, the chemotherapy that we mentioned. There's some other ones that technically fall in this bucket, like PNH and aplastic anemia. But I think the interesting one, Mike, maybe you could speak to this more, is marrow infiltration, like something that's kind of replacing the inside of the bone marrow with something else. And I literally have my note up here on pancytopenia, and I have 4 buckets for bone marrow infiltrative disorders. The first is malignancy, and that's of interest in this patient because of the prostate cancer. Solid tumors replacing the marrow, that phenomenon is called myelophthisis. The second bucket is granulomas, which I split into infectious and non-infectious causes. And it sounds like this guy hasn't been immunosuppressed yet from his chemotherapy, so maybe infection's less likely. And non-infectious granuloma sarcoidosis is actually on that differential diagnosis, and it's curious that he had his therapy stopped, the methotrexate, recently. Pure fibrosis can do this, as in myelofibrosis. That's like a primary marrow disorder. And then histiocytes can also infiltrate the marrow too, which I don't think we need to talk about quite yet. But yeah, I guess, Mike, what were your initial thoughts to this? And I'll start thinking about what we want to do kind of for workup, because off the bat, the usual stuff I would do, I think doesn't fit the tempo that we're dealing with here. Because again, I think it's acute to subacute. So I'm going to sit on that while I get your thoughts.
I think the infiltrative component is where my brain sort of just naturally went once we heard the diagnosis of sarcoid, particularly since he's not on treatment currently. He does sound like he has some amount of immunosuppression on board with this dexamethasone for his back pain, but not on, doesn't sound like it's directed at sarcoid treatment. So I actually agree. I think that's kind of where my brain went first. I think, this is a guy that needs a smear and hemolysis workup because, anytime, again, by cytopenia, regardless of what the white count's doing, if you see anemia and thrombocytopenia, especially this degree of thrombocytopenia together, that this is not really how a Maha presents, but in terms of how he looks, but it's something that kind of just needs to be ruled out. So that'd be the other thing. And yeah, I think that you kind of already asked Andrew about like viral prodromes, because we know that there's many different viruses that can do this as well. CMV is actually happens not infrequently in immunocompromised hosts, and I would say with his dexamethasone, I don't know the dose, but he may be. But then parvovirus is the classic, and EBV, VZV, these things can do it too. And then you mentioned already the building blocks, right? So it doesn't sound like this is a guy actually who is sort of withering away from metastatic prostate cancer based on the exam, but anyone with metastatic cancer can just not eat well and get behind in terms of nutrition. So that's, I think, also on there. But I think I agree. I think I'm drawn the most to things that are infiltrating, and I guess sarcoid.
Oh, I love we're on the same page, Mike. And I'll say what we're going to look for on the blood smear in terms of evidence for infiltration is this finding called leukoerythroblastosis. It's a very long word. It refers to immature white cells like myelocytes and metamyelocytes and nucleated immature red cells on the smear. And then you can have plus or minus teardrop cells on that smear as well. That pattern of finding basically suggests there's something crowding the bone marrow inside and basically forcing out all of these immature cells into the periphery. And Prof. at CP Solvers calls this teardrop cells, evidence of the bone marrow crying from something basically destroying it from the inside. And just some other fun things we could see on the smear. I had this in my notes from before. You can look for red blood cell inclusions. If you see red blood cell inclusions on a blood smear, that can be evidence that there's basically something wrong with hematopoiesis, because if the red blood cells aren't maturing properly, what's inside of them basically doesn't get expelled as it should in development. And what you see on the smear is those little guys inside. That could be in the form of basophilic stippling, Pappenheimer bodies, or Howell-Jolly bodies, or different names for particular things that you're seeing that are different inside. Anyway, Maddie, how did you all go about working this up? Maybe we're heading toward bone marrow after this, maybe.
Yeah, phenomenal discussion. I love hearing how you guys are thinking through this. All right, so I'll bring you to when he was admitted to the hospital, so got a repeat CBC, and this showed similar findings of a white count of 2.9, hemoglobin of 6.6, platelets of 20,000. The MCV was 98. And then, as you pointed out, kind of getting at the time course, we were really interested to see how long had this been going on. And 1 month earlier, he had some labs, and his white count was normal. His hemoglobin was 7.8, and his platelets were 139. And it seems like he had kind of been seen by hematology and oncology for this prostate cancer. And so he had previously, had workup that they were thinking this is kind of chronic iron deficiency anemia. And they were thinking that the anemia was from bone marrow failure from his prior radiation. But that's kind of where they stopped with the workup at this point. So then in the ED, before I give you kind of the workup that we did, so he received a unit in the ED, and during the transfusion, he developed a fever, a temperature of 38.7. His heart rate increased to 131. He was tachypnic, ultimately received IV Benadryl and Solumedrol with resolution of those symptoms. Never had skin flushing, abdominal pain, or kind of worsening of his breathing status. But maybe before I give you additional workup, would just love to hear kind of what you think about that reaction to the transfusion.
So it sounds like he had a febrile reaction while he was getting blood, or was there?
Yeah, febrile reaction while he was getting the blood transfusion.
Yeah. So, transfusion reactions, the first time I saw one as a resident, actually, I was kind of embarrassingly late in my residency. And I remember the intern running up to me, because they're very scary, actually, when, because you learn about them and then you don't see them. And then all of a sudden you see it and it's so acute. And so, I ran to I think I was as scared as the intern was, to be totally fair. But basically, it's important to think about in terms of transfusion reactions, put them in 3 buckets. So there's the truly like the hyperacute right away. That's this patient, right? Then there's sort of like the, this is 6 hours to 12 hours later. And then there's like the true delayed reaction that happens like a day or 2 later or even beyond. So right away, there are really kind of 3 big ones. The first is just true allergic reaction, anaphylaxis. And this is really like, it's an IgE mediated process. They'll have the symptoms that people get for any IgE mediated process, right? So they'll get hives and they're itchy kind of in the most minor scenarios, but, angioedema, stridor, hypotension, like that's kind of course, the scariest thing. And you need to, obviously you need to treat that pretty seriously the way you would any IgE mediated process. The one thing to know there is actually, for some reason, those patients with IgA deficiency, that can happen more often. And so if someone has that, and then, eventually once you get them stabilized, just think to look at that. So, and to me, it sounds like he's not terribly, sorry, was he terribly itchy with this?
He wasn't itchy. It was mainly just the fever, really.
Okay, so that probably is not the case then. And so then the two other things, right, are both febrile, and also, I mean, you can get a fever with an allergic reaction like that, but not as common. So then there's basically a hemolytic febrile acute process or a febrile non-hemolytic transfusion reaction. And what's important to know is that the febrile non-hemolytic is pretty common. It's about 1% of the patients that get a blood transfusion. And so that's 1 in 100, which, you know, if you're working in a hospital, you're going to see 100 people get blood. So this is going to be like the thing that's, you know, common things are common within 4 hours, basically, of the infusion, classically, as the infusion is still running. And really, you have to sort of consider this the same as you would an acute hemolytic transfusion reaction, because in the very moment, it can be challenging. From an HPI standpoint, usually acute hemolytic process, there is like flank pain, back pain, like these people are in much more distress. But you can be rigoring in either case, right? Because you just have fever. And basically, though, right, you send off the DAT and it's negative. You don't have signs of hemolysis on your smear, and the blood bank runs a lot of tests. But you sort of in the moment have to kind of consider it hemolytic and send the workup. And, you know, remember, this is just the non-hemolytic. It's just a reaction to the ill humors of the transfusion, right? It's not necessarily natural for our blood just to sit in a bag. So, and, you know, you don't need prophylaxis in the future in that case. You could do the leukoreduction to decrease the chance. But the most important thing is it's benign. They're going to be okay. They can get blood again. And you know, the way you get acute hemolytic is really the HBO, or the ABO incompatibility, which is, again, very, very rare now that we have such good blood bank typing. I'm gonna just mention the others, but I won't go in deeply because I don't think that that's what's going on here. My guess would be it's the third I mentioned, the febrile non-hemolytic. 6 hours to 12 hours, that's where you get the taco and the trolley. So, you know, the former being circulatory overload, so sort of the volume overload state of post-transfusion. Trolley is the acute lung injury. Again, you can see this with any amount of blood, but it tends to be your patients with like massive transfusion protocol dumping onto a patient who already has cardiopulmonary disease. You're not really sounding like there's any sort of cardiopulmonary manifestations here, and it's way too soon. And then, you know, you can get delayed hemolytic transfusion reactions a week later, and that DAT will be positive. And then, of course, there's, you know, like the 1 in a million chance that people get an actual infection from the blood, but that's extremely, extremely rare now. So my money's on the non-hemolytic febrile transfusion reaction, but I'm happy to be wrong.
That was a masterclass of teaching on transfusion reactions. That was so cool. And that's exactly what we were thinking it was, the febrile non-hemolytic transfusion reaction. So that was just so awesome to hear you teach on that. So thank you.
We only learned because we were scared once when we learned it before. That's the
exactly.
only...
That's often the driver for us to learn on these topics. You at one time feel like you lack knowledge on it. All right, so let me move on to some of the workup. So basic metabolic panel within normal limits. Liver enzymes, AST/ALT normal, actually had an ALK phos of 1.6 thousand. That had previously been elevated in around like the 800s when looking back at his chart. The peripheral smear that Andrew was asking for, so showed 2+ anisocytosis, 1+ dacrocytes, 1+ hypochromasia, no schistocytes. And then for the reticulocyte count, so the raw retic count was 1.99. When we calculated the index, that was low at 0.5. There was an LDH that was mildly elevated to 521. Normal bili, normal T-bili. Haptoglobin was normal. There was a mildly elevated fibrinogen, but normal PT and INR. We sent some nutritional workup that you all mentioned. His B12 was normal. So was the MMA.
Thank God.
Yeah. Folate and
Yes.
copper were also normal. Iron studies were consistent with anemia of chronic inflammation. And there was no recent kind of cross-sectional imaging, specifically looking at his spleen. But from looking at his past abdominal imaging 1 year ago, his spleen was normal in size. And maybe I'll pause there before sharing some of the infectious workup we did.
And Maddie, what did you say the retic index was again? You gave the absolute count. Was it
Hypoproliferative, so it was 0.5.
Okay, thank you so much. Really, really helpful. Um, Anisocytosis, we mentioned that on the anemia episode 2. It just refers to, I believe, cells of very different sizes, basically, what you're seeing, and that could be supportive of this leukoerythroblastic reaction, where you have these very, very large cells basically coming out when they're not usually that large because they're like in the immature phase. And the dacrocytes is the lingo for the teardrop cells. So I think we're seeing the leukoerythroblastosis, Mike, and maybe something's going on in the marrow. And I think it's really interesting Maddie gave us the information on the spleen too, just because one of those sneaky causes of peripheral destruction that can cause pancytopenia is hypersplenism. And that had briefly crossed my mind early when he said sarcoidosis earlier, is that anything that can cause a very large spleen, to my understanding, can cause this hypersplenism phenomenon where you can have slow sequestration and destruction of cells inside of the spleen, where that can lead to pancytopenia. So perhaps that's why she's giving us that. But when you're seeing the leukoerythroblastosis and retic index that's very, very low, I think we're all focused on the marrow at this point, and we need to know what's going on. Mike, the ALK-Phos, you get anything from that? I'm just thinking bony metastasis, prostate cancer, the LDH2, very non-specific with someone who has cells lysing everywhere from their cancer. That's really all I could extract in terms of helpful data for making progress. But did you glean anything else?
I don't think so. And right, even if we do think this is sarcoid, right, we would see those things in sarcoid, right? It's like you see lymphoproliferative anything with granulomas or lymphoid oftentimes will cause the ALK-Phos and LDH to be high as well. I will mention one thing though. With sarcoid in the liver, I think it's really helpful that we now know. I think we can feel pretty confident that we don't have hemolysis, right? And I think that we can feel pretty confident this patient doesn't have like cirrhosis. But one thing I think that's just like to know about sarcoid in the liver is that a lot of patients, I think like between like 10 and 20% will have only 10 to 20% will have elevated enzymes. Like a lot of them don't. Most patients don't have any changes in their LFTs. And when they do tend to be actually cholestatic. And the reason for that is really because these granulomas, they don't cause, if you think about them, like the granulomas themselves are they're not destructive to the tissue around them. What they do is they actually impede on things. So they press on like the biliary systems, either the small ducts or the larger ducts, the intra or extra hepatic, and same with the portal, intra and sort of more extra portal systems. So you actually just get like physical back pressure. And so, cholestatic injuries. You can also see people who have normal liver function, but portal hypertension and also thrombocytopenia from that. And that's, again, it's really more the nodules pressing on the biliary and the venous systems rather than like a destruction of the liver entirely. So that's just another thing comes to mind. And I think if I had to put money on something, I'm still thinking sarcoid. Maybe it's in the liver and it's also in the bone. But I agree with Andrew that at this point, need to take a look inside the bones.
I love it, Mike. Yeah, I think, Maddie, just a quick question. Is the next aliquot kind of the final diagnosis? Or?
No, I will give you one more chunk of some
okay.
studies and then the last aliquot. How does that
Okay. Okay, that sounds good. Let's do
All
it.
right, cool. So for some of the infectious workup, so blood cultures were negative, HIV was non-reactive. As I mentioned, he had a history of Hep C, so he had a positive HCV antibody, but a negative viral load. We sent EBV and parvo serologies. So the parvovirus IgG was positive. The IgM was negative. And then we sent a parvovirus DNA kind of PCR, which was also positive in the 2000s. EBV, IgG was elevated. The IgM was negative. And I will pause here. The next, we did a bone marrow biopsy that will reveal the final diagnosis, and I'll share that next.
Ooh, yeah, I think it's a really interesting last place to leave us. Uh, I think it's great we did the infectious workup, but just to go back on what we've been drilling over and over, I mean, the smear is telling us something's inside there, and many of these tests that were just given to us, that would have those diseases could cause deep pancytopenia, but they wouldn't have caused this peripheral picture of stuff being squeezed out of the marrow. Like parvovirus is like a aplastic anemia type of picture. When we do a marrow on that, you're just going to see like absent red cells. Is kind of my understanding. There's nothing kind of pushing stuff out. As far as those other ones, HIV, CMV, Mike mentioned earlier. Again, I don't think that's what we'd be seeing. So I'm still with you, Mike, on looking for the granulomas. And because it's our first episode where we could potentially entertain TB, we can't miss it, Mike. We can't miss TB. So we want the acid fast stain still on the on the bone marrow, especially because they were on methotrexate before. But yeah, I think a full staining of the marrow for infections, and then just looking for granulomas, like Mike said. But Mike, any final thoughts?
The PCR for the parvovirus was positive or negative? I want to make sure I heard that right.
It was positive, so there was a low level of DNA that for parvo.
Okay, interesting. I don't think I have any intelligent comment to that. I just wanted to make sure I heard it right. I don't have anything else to add, Andrew. I think it's let's take a crack. No pun intended, I guess.
Hopefully not a dry tap here. Let's see.
All right. So basically, the patient got a bone marrow biopsy, and the aspirate was consistent with carcinoma in the bone marrow. So ultimately, the final diagnosis was pancytopenia, secondary to metastatic prostate cancer that had invaded the bone marrow.
It's so unfortunate, Maddie. Yeah. I feel like I saw this once actually on the oncology service, where kind of before our eyes, as someone was landing, they developed pancytopenia, and the oncologists were all over it, like myelophysis, however you say it. I'm not sure how they say it. But yeah, this happens. I'm not sure what this means for the patient's prognosis. If presumably they hadn't started their treatment yet. I hope they did okay after, Maddie.
Yeah, what's really kind of rewarding about like reflecting on cases and kind of looking back through patients' charts, so you kind of see how their like story has unfolded. And he started on chemotherapy and has been overall very stable. Still kind of has the chronic back pain from those bony mets, but is still living at kind of his long-term care facilities, getting chemotherapy, and overall seems to be doing relatively well. And because as we talked about, he had already had kind of metastatic disease to the bone, so this was unfortunately an additional site. But really just kind of in awe of how you guys discussed, and it was so cool how so early on you were suspicious of a process infiltrating the bone marrow, even from like the first or second aliquot. So that was really, really cool to hear you guys kind of picking up all the clues for that. And then for the kind of transfusion reaction, we were thinking exactly that this was the febrile non-hemolytic transfusion reaction because of the time course and all of the reasons, Mike, that you shared. And then interesting just to touch on kind of the parvo. So basically those serologies we were thinking were consistent with kind of prior past infection, positive IgG and that kind of low-level DNA is non-diagnostic, but may reflect kind of a past infection. But exactly as Andrew said, not kind of the explanation for the pancytopenia for all those reasons. So that's where we are with the case.
Thank you so much for sharing, and I'm glad to hear he had a good response to the chemo, because I'm just, as we're sitting here, I just Googled full discretion, metastatic prostate cancer to the marrow, and it does look like it does have a worse prognosis for sure than prostate cancer that's not in the bone marrow, which isn't terribly surprising. I'll just say this: I have no idea if this is accurate or not, but we think about who gets the worst of parvovirus, right? It's people who have inherent issues with blood production, right? I mean, sickle cell's the classic. So I don't know. I guess I just wonder if PCR is. It'll be reading I have to do, but I don't know how parvovirus would circulate for weeks or months with a DNA level. I feel like he may have had an infection in the last month, and maybe the IgM's cleared, or maybe he's not making good serology. But either way, it was like a second hit, like he had infiltration, then he got infected with parvovirus, and sort of it was not that it was the cause, but like, because Andrew said, right, like we're seeing lots of signs of infiltrative disease, and then of course the marrow is showing us that. But I just wonder if that was part of the tipping over into the more frank pancytopenia, just because of the DNA. I'm going to do reading on that though, because it's very well could be incorrect that's something that lingers for a long time.
Yeah, it's a really interesting hypothesis, Mike. I'll be curious to see where that lands. My final thought is just another way the spleen was kind of relevant to this case, apart from the sarcoidosis. So this syndrome of myelophthisis, or anything infiltrating the marrow, if the marrow starts to fail more chronically, the spleen will actually get bigger. That's basically compensatory, is you need to make cells from somewhere, and the formal word for that is extramedullary hematopoiesis, and you see that in the form of splenomegaly. Just another thing you could have paired with the blood smear findings that kind of point toward marrow infiltration. But great bread and butter case, Maddie. I think this is a concept that when I started residency, I didn't think about too much. We think about like liquid cancers causing marrow failure and marrow infiltration, where things really originate, but that other way around, like solid to bone marrow, I didn't think about it until I did my oncology service and saw that one case I was referring to. So thanks so much for bringing it, Maddie. I think this is a really good one for the podcast. Everyone's really going to enjoy it.
Yeah, no, it was, as I said, so awesome to hear you guys discuss it. And it was cool in real time because, the patient had like a few reasons for pancytopenia, between the radiation that he had in the past, the sarcoidosis that you guys picked up on, the question of, he has known metastatic prostate cancer. Could it now be in the bone marrow, which ultimately was these prior infections? So lots of kind of possibilities that were on the table, but this is ultimately what it was. And as you said, bone marrow is not, the bone, I learned, was actually the most common site of metastasis for prostate cancer, followed by the lymph nodes and the liver, as you said, but the bone marrow is not as common, and kind of leads to a worse prognosis. Yeah. But it was a great case to learn from, and awesome to hear you guys discuss it.
Oh, okay. I lied. I actually have one more reflection. I was thinking, invoking cancer complications in the inpatient, it varies in how confident we are to add that label depending on the site of pathology. I'm just thinking of how many people come in with like nodules in the lungs, but people aren't like, oh, it's not lymphangitic carcinomatosis. There are a million other things that can cause that, and it's pretty far down on the differential. But when someone comes in with like pretty subacute, deep pancytopenia like this, and you've ruled out the nutritional stuff, you're not left with too much stuff. So it's really interesting how quick you can make that leap in that space. But if you look elsewhere, like the lungs and other organs are going down a little bit more slowly, people are more hesitant to blame the cancer. But I think in this case, there's not too much that could have done this in this patient, once you've of course assessed for the sarcoid and the infection. But just an interesting thought. Thanks again, Maddie. So good to see you.
Good to see you both.
It was great to meet you, and we'd love to have you back. This is great. Thank you so much.
This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.